after about 2 decades of sterility, valvular heart disease has taken off a new tack, and it's become important in our therapies for a lot of reasons. First of all, you can hear it. You know that it's there. Many types of heart disease, you don't know they're there until it's too late. You've had forewarning that the patient with valve disease has it because of the heart murmur that it causes. All severe valve disease is universally fatal if you don't treat it right. And at the same time, proper therapy can confer normal lifespan. So it's important to recognize it and know how to treat it. And then just 48 hours ago, there's this. The FDA released the percutaneous aortic valve, not for general marketing, but to the public in a limited way. So this valve will be available in some centers that have demonstrated a collegial activity between surgeons and cardiologists, and centers that have demonstrated excellence. Interestingly, the sales force and marketing forces are going to be compensated not on how many of these $30,000 percutaneous devices they can sell, but on the outcome. And so they're going to be very stringent about who gets to have a percutaneous valve, and we'll talk about that as this goes along. It was approved essentially for inoperable patients through the transfemoral route. So this valve goes in on a balloon, it gets up to the aortic annulus, the balloon is expanded, the stented valve is put in place, and the catheter is withdrawn. It's a stented valve, and it's a remarkable device. Medtronic is about a year behind, and they will be releasing their valve, or I'm sure the FDA will be releasing their valve in about a year, but obviously the ability now to treat people percutaneously in the cath lab or in a hybrid OR, as opposed to in the operating room, is a game changer. And this is just the beginning. These technologies are advancing as I'm sitting here giving this lecture. I guarantee you the engineers back at Edwards and at Medtronic are figuring out ways to make these things better as I'm standing here. So, of course, you'll recognize aortic stenosis by the classic systolic ejection murmur that radiates to the neck and the classic delayed carotid upstrokes. And you put one hand on the patient's apex and feel a powerful apical beat, and the other hand on these delayed carotids, and you know that there is an obstruction between your two hands, and that's aortic stenosis. You hear the murmur, all these people need an echo, they go off to the echo lab, and if the jet velocity across that valve is greater than 4 meters per second, it's virtually always going to come up with an aortic valve area of less than 1.0, and that's how we, in the guidelines that made up these guidelines for the treatment of this disease, defined severe aortic stenosis. So we'll start off with this patient, a 57-year-old man who's asymptomatic, typical murmur. He's got mild to moderate disease. It's not yet in the severe category. And the question is there anything we can do to retard the progression of this disease? Now, when I was a fellow and we looked at this valve, we said, that we call that degenerative calcification, whatever that meant. It implied that there was sort of wear and tear on the valve that caused this calcium to be deposited. But then in 1992, Otto and her colleagues looked at a group of patients who died not from aortic stenosis, but from automobile accidents and other causes, in which she could look at the very early plaque of aortic stenosis and found that the early plaque of AS looks very much like the early plaque of atherosclerosis, of coronary artery disease. And in fact, I'm sure that it is. It has the same risk factors in common, and there is co-alignment or coincidence of coronary disease and aortic stenosis in about 60% of patients. Not universal, but there. And then that gave rise to the idea, well, maybe since statin agents have been so effective in the treatment of coronary disease, we might be able to use statins to slow this down. Well, in the SEAS trial, randomized, this is the largest randomized trial in valve disease. I want to point out from the beginning that the guidelines for valve disease, again, of which I'm one of the authors, are unique in all of the ACC AHA guidelines in that not a single one of our recommendations, not a single one, is supported by a level of evidence A. There aren't randomized trials. There are over 6,000 randomized trials in cardiology. Only 15 of them, pertain to valve disease. 15 out of 6,000. And this is one of them that randomized patients to placebo or Vytorin, which you may know is a combination of simvastatin and ezetimibe. The Vytorin crushed LDL levels, dropped them from 135 to 50. An amazing drop, but unfortunately had absolutely no effect whatsoever on the progression of aortic stenosis. Now, those were patients with moderate disease. The Astronomer trial looked at milder disease and used rosuvastatin. It had exactly the same results. Okay, so statins didn't work. Maybe it's not surprising. In coronary disease, statins work by presumably reducing the incidence of plaque rupture. And in aortic stenosis, the disease is occurring by these calcium plaques that develop on the valve, impeding its motion as opposed to rupture. So maybe it's not so surprising, but I guarantee you we'll be continuing to look for pharmacologic targets to help retard the progression of this disease. Fortunately, none are going to occur before I get my kids out of college, because be a shame to see this go away. It's kind of a fun disease. And anyway, so this patient's a bit more interesting. He's 71 years old, and he says that he can do anything he wishes to do, that he's asymptomatic, he's doing fine. His physician hears a murmur, sends him off to the echo lab, where we find a jet velocity of 4.3 meters per second, a mean gradient across the valve of 60 millimeters of mercury, an aortic valve area of 0.8. He still has a preserved ejection, and he's got heavy calcium in the valve. A patient with severe asymptomatic aortic stenosis. And what do we do with him? If you go back 40 years to these very famous data published by Ross and Brownwald that indicated that the patient with aortic stenosis undergoes this latent period during which there are no symptoms and survivalship is nearly normal. And then once the patient with this disease begins to develop symptoms of angina, syncope, or dyspnea, they begin to die at the rate of 2% per month. Now, there aren't many diseases in all of cardiology or in all of medicine that kill you at the rate of 2% per month. So the advent of symptoms is an important demarcation in the disease. Now, there are differences between then and now and similarities. The differences are that if you look today, our patients are about 30 years older. The average age of the Ross and Brownwald data was 46. They were mostly looking at congenital aortic stenosis and rheumatic disease. That's changed. We now have this atherosclerotic kind of disease that shows up in your patient's 70s and 80s. So that's the part that's changed. The part that is exactly the same is the death rate once patients develop symptoms. So if you have a patient with symptomatic aortic stenosis, easiest decision in all of cardiology. Either fix it or let them die. There's nothing in the middle. And so, but this guy, the guy I just presented to you, is asymptomatic. And we know that if he truly is asymptomatic, he's fairly safe. Pat Pellica and her colleagues at the Mayo Clinic looked at 622 asymptomatic patients with an average jet velocity of 4.5, just like our guy. Severe asymptomatic aortic stenosis, and at follow-up, they were censored when they either developed symptoms or got an operation. But if you look at, there are no controlled trials, and there's never going to be one. But here's a referent population. This is a normal U.S. population matched for age and gender without aortic stenosis. Here are her patients, not statistically different in survivalship. Rosenheck and his colleagues in Vienna, 116 asymptomatic patients with severe AS, only one sudden death in 6 years. And if you look at all the data that's out there, and there's not much, there's about 1,300 patients in the literature. The risk of sudden death in the absence of symptoms is about 0.4% per year, which is about all of our chances of dropping over dead. So it's not much different than the normal population. That's reassuring, but there is worry. Because in Pellica's study, there were 11 patients who dropped over dead without symptoms. And if you look across the literature, there's about another 26 or so patients that went very rapidly from no symptoms to being dead. So there is some concern for my patient. If we operate, he'll do quite well. You can easily, any of you can just Google STS risk, pick up the STS risk calculator on your laptop, and in about 1 minute and 30 seconds can get a pretty good predictor of what the patient's risk would be. And when I put my patient through the score, it predicted a 0.7% operative risk, pretty low, less than 1%, and that after the operation, there's a 93% chance he'll be just fine. So I'm kind of between a rock and a hard place. It's low risk to do something, and it's low risk to do nothing. But I've got to tell him something. I have to give him a recommendation. So my strategy is to look for a high-risk group of asymptomatic patients in whom it would be advisable to operate, and a low-risk group in whom it's okay to go ahead and continue to watch. And I think we can do that. So that Catherine Otto, looking at jet velocity, if the patient enters your office with a jet velocity of less than 3, the chances that he'll need a valve in 5 years is less than 10%. On the other hand, like our patient, with a jet velocity of greater than 4, the chances are he's going to need a valve, 70% chance in 2 years. And Rosenheck amplified that a little bit more, looking at even higher jet velocities. You have a patient with a jet velocity of 5.5. They're not going to go 1 year without a valve. So jet velocity can help you segregate patients. So can calcium. How did that calcium get there? This valve is a sea of inflammation. There are parts of the aortic valve in patients with aortic stenosis that are a full degree Fahrenheit hotter than other parts of that valve. There is active inflammation going on, and that inflammation leads to calcification. And the more calcium you have in the valve, the sooner the patient is going to come to symptoms and an aortic valve operation. And then the question, I made a big deal about symptoms, but you all know your patients lie. Well, they don't exactly lie, but they deny symptoms. But that's the key thing to look at. And that's why I exercise every asymptomatic patient with aortic stenosis. So you say, I thought you weren't supposed to exercise people with AS. Yeah, you're an idiot if you exercise the symptomatic patient with AS. They're going to die on the treadmill. They need to be in the operating room. But if they're asymptomatic, they're going to exercise anyway. And wouldn't it be better to have them exercise in front of you? And that's what Tony Doss did, exercised a group of patients with aortic stenosis, those patients who had a truly negative test, no symptoms. They achieved 75% of their age-predicted exercise tolerance and had a normal rise in blood pressure. A year later, they were virtually all okay. Whereas people who flunked their test, more than half had required a valve replacement within a year. And so the exercise test is a useful segregator of risk. So what to do with this guy? Well, he went up on the treadmill. He quit after 3 minutes, and he looked at me and he said, "Doc, I didn't do so good, did I?" And I said, "No, you didn't." And after his aortic valve replacement, he said 6 months later what so many of these patients say. "You know, Doc, if I had known how good I was going to feel after this operation, I'd have had it done 3 years ago." And I suspect he'd been symptomatic for 3 years. So what about now that this percutaneous valve is available? Would that help me decide what to do with this guy? Would putting one of these in solve my conundrum? Well, no. This percutaneous valve is going to be released for people like this. An 87-year-old lady with severe lung disease, a previous CABG, porcelain aorta, renal failure, the kind of patient for whom the surgeon are getting out their 11-foot poles because they ain't going to touch her with a 10-foot pole. In order to get a percutaneous valve, you've got to be turned down by 2 heart surgeons. And you know, that patient had an STS risk score of 13% at least. So this is Partners B. This is the result of one of the, I think, best done randomized trial in the history of our country, where patients with severe inoperable aortic stenosis were randomized to usual, medical therapy, whatever that means, versus the percutaneous valve. A 50% reduction in cardiac death. Whatever, I mean, that's not, 50 percentage points. What other trial do you know? What other thing have we ever done that causes a 50% reduction in mortality? So for the inoperable patient, this is a game changer. What about for Partners B? So Partners A was the other part of this randomized trial that randomized patients who were operable but at high risk to either surgery or a percutaneous valve. And you'll see that there was no difference in survivorship. But the reason that the FDA did not release this valve to high-risk patients is because of the fact that in the TAVI group, there was a substantially higher risk of stroke, twice. Now, it's not so surprising. You're taking this big thing and running it up the patient's aorta, no doubt scraping off, various debris that are in the way and releasing them to the carotids. So, as I say, right now, I guarantee you the engineers are trying to figure out a way around this. But that's why this valve is not being released to anything other than inoperable patients. Now we're going to go to the other end of the spectrum. Here's a 76-year-old man, pardon me, who has dyspnea with the simple activities of daily living. He gets out of breath brushing his teeth in the morning. 2/6 systolic ejection murmur. He's only got a mean gradient of 19 with an ejection fraction of 19%. Very high BNP, and he goes off to the echo lab where he is infused with dobutamine, and nothing happens. And what do we do with those data? This triad of low gradient, low output, low ejection fraction is the highest risk group of patients with aortic stenosis. You take a patient with a big fat gradient like that, 100 millimeters, and even if their ejection fraction is low, it'll return to normal probably on the first postoperative day, because the surgeon got rid of all that afterload. He took that tiny little hole and made it bigger, and now the heart can contract again. So high gradient is no problem. That's afterload mismatch. It's cured in the operating room. But patients with low gradient, this group down here, gradients of less than 30, in this small study that I performed many years ago, with 100% mortality, was a high-risk group then, it's a high-risk group today. Levy and colleagues reporting in JACC, looking at gradient and outcome, patients with gradients between 20 and 30 had an operative risk of about 15%, and a 40% mortality at 5 years. People with gradients of less than 20, like the patient I just presented to you, an operative mortality of 35% and almost nobody alive 5 years later. Very high risk group of patients. Dobutamine challenge, looking for inotropic reserve, is a useful stratifier of operative risk, so that patients who have a positive dobutamine test, that is to say, their stroke volume goes up by 20% or more when they're given dobutamine, have a 10% operative mortality, reasonable, not great, but reasonable, and a pretty good long-term outcome. They do far better than that same group treated medically, who, after all, have symptomatic aortic stenosis and whom you could predict that they were going to die, and they did. They also did better than group 2 patients, patients who failed to have an inotropic reserve response, who had a 30% operative risk. The kicker is here. They follow these patients up. 30% of the dobutamine negative patients are dead and make it through the surgery. But for the 70% that did, their ejection fraction improves every bit as much as the dobutamine positive. Dobutamine helps you predict operative risk. It does not help you predict postoperative ejection fraction. And this is, I believe, sort of the last frontier in aortic stenosis. What do you do with the dobutamine negative patient? High operative risk, but if they survive surgery, they may do very well. And I don't know how you figure that out. We haven't gotten there yet. So what to do with this guy? He's got he's got a gradient of less than 20. He has no inotropic reserve, and he's in bad shape, and he did not especially want to undergo surgery anyway. So we recommend that he not have an operation. I think it would have been a very high-risk procedure for him. Suppose I could put a TAVI in him. Well, it may be a good idea, because this is a wonderful valve. Hemodynamically, it's close to perfect. There are no struts. It's a much different valve than other valves that are available, and the gradient across these valves in this guy be almost zero. The thing is, he was specifically excluded from all the trials. Manufacturers don't want a guy like that in their trial. I mean, you're loading the dice against yourselves. So we don't know yet how he would respond to a TAVI. Maybe a good idea, maybe not. There's just no data to help us know what to do. So aortic stenosis is a disease akin to atherosclerosis. And in going forward, we'll be thinking of ways of treating it as we learn more about both diseases. Symptoms are still primate. The guy's got symptoms. It's the easiest decision in medicine. Fix it or let him die. It's that simple. They are not going to survive more than 2 years in the presence of symptoms. Some asymptomatic patients, I believe, should probably have an aortic valve replacement. And those are people with a high gradient and severe aortic stenosis, a valve area of less than 6. Those people who have a positive exercise test, heavy calcification, probably those with severe left ventricular hypertrophy, and lifestyle. I'm going to leave you in a couple of hours to go back to Houston, and I really don't want to hear that both pilots have a gradient of 80 millimeters of mercury. I mean, there are some lifestyles, there are some things that people do for a living that would probably make it advisable for them to go ahead and have an aortic valve replacement. TAVI is a great challenge for us. We, I think, as a cardiologic profession, did not do our patients any favors, did not proceed in the best possible fashion with percutaneous coronary intervention. There are folks out there with stents that have no business having stents in them. Now, I believe that we approach this with what I call the tumor board approach. If you have a patient with cancer, the radiation oncologist, the medical oncologist, and the surgeons don't fight over him. His case with the pathology, the histologic cell grade, all the data about that patient are presented to a tumor board where the radiation oncologist, the medical oncologist, and the surgical oncologist look at that patient with his tumor at that stage and say, the data say this is the best thing to do. And I believe that we need to go forward with these percutaneous devices in the same way, with our patients being presented to all of the specialties involved so that the decision can be made what's best for the patient, not the flavor of the month.